Good afternoon, everyone. Thanks so much for being here. I'm Dr. Pam Schaff, and I'm the director of our HEAL program, Humanities, Ethics, Art, and Law. And this event today is part of our continuing mission to align the work of patient artists with our medical school's core curriculum. And we do that to enhance understanding between patients and our future health professionals. So it gives me great pleasure to welcome today our artist, Janice Grinsell, who Ted is going to introduce more fully. But I also want to welcome Dr. Hsieh, who is an assistant professor of clinical surgery here at Keck, and Dr. Syma Iqbal, who's an associate professor of clinical medicine at Norris. So with that, Ted, I'm going to hand you a microphone.
Hi, everybody. Well, I always start with a couple facts. So this is stuff I pulled off the internet, so take it for what it's worth. But 140,000 new cases of colon cancer every year. So if you guys decide to go into this field, you will never be without patients. And one of them is next to us, Janice Grinsell, who I knew from San Diego more as a sort of performance artist. We were in a show together, and she was sitting in a bathtub while people were coming by for a long time, and for the life of me, I didn't really know what was going on. But I've always loved her photography, so why don't you tell us a little bit about first your diagnosis and how you realized that something was going wrong.
I'd like to thank you all, and it's an honor to be here with everybody today. It's interesting, my diagnosis. I think if I wasn't a runner, I probably wouldn't be sitting here with you all today. For the most part, I felt that I led a pretty healthy lifestyle. I'd been a pescatarian since I was 28, eating organic whenever possible. I incorporate exercise and meditation into my daily routine. And I also had a strong belief that I was living under the protection of a good genetic umbrella, because my mom, who is 94, although she has Alzheimer's, is the perfect picture of physical health. She still plays tennis twice a week and often has more stamina than I do. But I learned something very interesting, and that is cancer knows no bounds. It was December of 2016, and I was taking care of my mom where she lives in Florida. And accustomed to running 3 miles a day, I found I was tiring very early on. So at first I thought it was the humidity, because I'm from San Diego. And I moved from running outside to inside the gym, but there wasn't a change. So when I returned to San Diego in January of 2017, I contacted my physician, and I explained the situation, and he said, well, let's order some blood work. It came back showing that I was anemic. And it had only been 3 months previous to that. I'd had an annual physical, and I was fine. So he felt that I was bleeding somewhere and ordered an endoscopy. When that came back clear, he apologized for having to order a colonoscopy, stating that it had only been 5 years previous since my last colonoscopy, and under normal circumstances, I wouldn't be due for another 5 years. I remember not waking up, but I remember being under the twilight and feeling the sharp pain. And when I woke up from the twilight, the dreaded words, "You have cancer," stunned me. Plans were made immediately for me to contact the surgeon, and I was given a number of an oncologist to follow up with. And 1 week later, I had a hemicolectomy. And the tumor was large. It was a T4. It had broken through my colon wall and attached itself to my abdomen. The surgeon said that, he assured me, he said that he had scraped and scraped where the tumor had been attached, and he felt in his heart of hearts he had removed it all. So that was reassuring to me. Because physically, after the surgery, I was fine. It was done laparoscopically, and I was left with just 2 tiny little incisions, but mentally I was a frightened mess. Now the chemotherapy seemed a lot more scary than the cancer. And coming from a holistic mindset, it was too difficult for me to agree to put toxins into my already compromised body. So since I was a stage 2 and the surgeon felt that he'd removed all of the tumor, I opted out of the chemo that the oncologist was prescribing, and I started to research alternative methods on my own. This is where it gets interesting. It was at that point the oncologist offered me the OncoDX test. She said that they could map my tumor genetically and tell whether or not the chemo would even work and what my recurrence rate would be. So I asked her why that option wasn't given to me in the first place, and she mentioned something about maybe my insurance not paying for it. As it turned out, the chemo wouldn't have worked on my tumor. My recurrence rate was only 7%, and my insurance did pay for it. So what I chose was close monitoring as my option, and in addition to that, I stopped all refined sugar and started to take supplements to help boost my immune system.
I want to talk, all of us, about her title, because it's a pretty provocative title for this show. And my mom had cancer, and there was a certain point where she just decided she didn't want to do chemo again. Janice made a decision to not do it after getting all the facts. And you know, whenever you're dealing with cancer, it's such a strong word, and death immediately comes into it when you're treating people. So we'll talk about Janice's artwork in a second, but I want to talk about how you guys deal with patients when that comes up, because it's the first thing on everyone's mind, and all these students are going to have to deal with life and death situations. So why don't you guys talk about when you're first saying to someone your tests are positive, you've got cancer, how do you deal with it? And then Janice will talk about sort of how she dealt with it.
Hello, okay. I can comment on that a little bit as far as when I see the patients in the process of their workup. And that generally is either giving them the new diagnosis after a colonoscopy, such as you had, or having the patient referred to me from another provider who has already told them about a possible diagnosis of cancer. And so from my perspective, I think I get into their life story towards the beginning, where the attitude or the approach to their battle might be a little bit different. And so a lot of times when people are thinking about fighting the cancer, they think about surgery as a hopefully one of the first steps or one of the very active areas that they can participate in as far as their overall course with their illness. And so quite often when I talk to patients, the idea of death doesn't necessarily enter our conversation. I think a lot of the times people are thinking of that as perhaps down the line, but in the point where I meet them, it's generally they're looking at a problem that they can try to tackle right away, and then all the other stuff they kind of put aside for now. And so when we talk about the treatment plan, often we focus on very positive language, for instance, like preparing for a fight, getting ready, getting as healthy as you can be to take on this next step. And it tends to, I think, afford a lot of my patients a bit more comfort as far as knowing that they have some measure of control or a lot of participation in what's going on, and they have very much an active approach to their treatment.
So I'm an oncologist. People run from me at parties because I'm associated with cancer, and cancer is associated with, as you said, death. So I think as I approach the patient, and I think what happens with most oncologists is that we're generally we're the physicians or we're the guide to the entire disease process and where the patient is in their process. So what usually happens is I see a patient after a surgeon has seen a patient, and the surgeons are there to fix a particular problem, so they don't necessarily take the whole approach to the patient. So the first time the patients are actually hearing about the entire approach to their disease is usually when they see the oncologist. And depending on who they've seen before us, they already have an idea where they've been guided by their prior providers of where they are. And so sometimes that's hard for us because we're perceived as perhaps the bearer of all bad news. But I think it's important for us to provide an approach to overall care. So usually when I start with see a patient, I start with what the goals of the therapy are going to be based on where they are in their disease process. So if I'm seeing someone who's had resection and has no evidence of disease, and we're talking about giving chemotherapy to prevent the cancer from coming back, then the goals of care are curative. We're trying to cure you of your cancer. If I'm seeing a patient and their disease has spread, it's metastasized, and perhaps we're not going to be able to do anything to take it out or cure it, then the goals of care are palliative, to control the cancer. And so I think the first step in talking to a patient is to make sure that we both understand what the goals of the treatment are. And so even now when we talk about not curing a cancer, I want to put this in context. We don't cure a lot of diseases, and I'm not trying to be, to minimize this, but, we don't cure diabetes. We don't cure HIV, but patients stay on therapy on and off potentially for the rest of their lives, and they control their disease. And now with HIV, people are living normal lifespans. There are many cancers now where patients are living many, many, many years, in some cancers with just a pill. When I was training, these were cancers that were incurable. So we've come a long way. And I think when we think of any disease, we think, oh, I want to cure the disease, but I think we have to think about controlling it as well, and controlling it as being a very viable and positive option for these patients.
So let's talk about Janice's artwork, and you guys can tell us what you think, but why don't you explain to us what this project is and how you did it and what you were trying to get us to see in these images.
Okay, well, let's start with the title. It's interesting. With the cancer diagnosis, a whole new reality presents itself. You could die, not with other diagnoses necessarily. And we know that stress and anxiety make it hard for the body to fight disease. So for me, accepting the possibility that I could die, I feel helped to stave off those negative effects. The work is an introspective look at the multiple intersections of cancer as a diagnosis, with mortality as a strong possibility, and of course, hope is a necessity. The work, shortly after my surgery, I was approached by two photographer friends, Chris Moore and Amanda Dahlgren. They were doing a project, Portraits of Strong Women, and they asked me if I'd like to participate. And I was really flattered, especially thinking to myself, this is hardly how I'm feeling right now as a strong woman, but great. And I agreed to meet them at their studio, and after about an hour or so of positioning my face for best possible angles and expression, lighting. They seemed satisfied with the photos they had taken. I asked them if they wouldn't mind taking some photos for me, because documenting my fear and vulnerability was something I wanted to do. And they agreed, so I proceeded to undress and randomly positioned myself using props, symbolic props, such as ties and a blindfold, to emphasize the helplessness and confusion that I was feeling. The photos they took were arresting, and I knew I needed to use them somehow as testimony to my endurance. Shortly after receiving the color photos from Chris, I turned them to black and white and chose to intuitively mark them with pastels. And I manipulated the photos by layering them with images of organic matter. When I enlarged the photos, they distorted. And that distortion was very familiar to me. Now I felt like I was distorted inside. My life had changed so rapidly, it was almost surreal in many ways. So a dear friend of mine had given me several rolls of wallpaper, and I decided that I would suture the photos to the wallpaper, making life-size panels. And in addition to those manipulated images of me during my cancer scare, I chose to tie, knot, and stain sheets with turmeric, which I then layered between wax paper, and I made similar 6-foot panels with those as well. I chose turmeric because of its natural anti-inflammatory properties that's often used to help combat disease, and I also feel that those fused objects, they depicted the best word I can come up with is the disturbance that followed my diagnosis and the overwhelming sense of powerlessness I felt. They were to be originally since they were 6-foot panels like the photographs, they were, the whole show was supposed to be an installation. And those panels themselves were supposed to be creating a labyrinth that you would walk through, and then you would come upon the 6-foot panels of myself. But that exhibition never came to fruition because in the middle of it, in 2018, my husband was diagnosed with esophageal cancer. And I needed to abandon it to help fight for his survival. He had a near brush with death, not necessarily because of the cancer, but it was the treatment. He was in the hospital for many months, and he had a long recuperation. He had to learn to move again. He couldn't even turn on his side. So cancer has affected me, not just myself, but my family, you know, and I want to say that I almost feel like, and especially after speaking to you and knowing how many people come to you on a daily basis with colon cancer, and that's just one type of cancer. It's like the plague, and you're almost lucky if you don't get it. And it's not just an old person's disease anymore.
So I want to talk about this idea of like accepting. I just keep getting back to the death because I remember my mom had lung cancer, and there was a certain point where she went to the doctor and they gave her treatment options, and she just said, "I'm 84, my friends are dying. I don't want to deal with it." And in other talks, we've had patients talk about when they went to the doctor, and immediately the doctor was all into, we're going to do everything to keep you alive. And there was almost a guilt if they decided they didn't want to try to do everything possible to stay alive for quality of life. And so how do you balance that? I mean, do you get people who come in like Janice who just go, I'm going to throw the dice and accept the fact that it might not work? Or do you it seems like these guys are all here, they're learning, they want to save everybody's life, but some people just want to live out their natural life. And
I tend to see patients more in their acute phases. So often when they're newly diagnosed, or if they have a problem that requires surgical intervention, even after their diagnosis. So anything from bleeding, obstruction, things that you don't necessarily think about being associated with the primary cancer necessarily. And so I know that there's a lot of assumptions that we make in the course of treating patients about what the general average person's wishes are. And it does take some conscious effort to remind yourself that not everybody has the same version of hope that you have for them. And one of the things that I learned early on, even as a medical student, was that for a lot of people, they don't necessarily understand right off the bat that hope can change. They think that hope is necessarily tied to a specific outcome. And after you maybe spend some time questioning what their values are and what their goals are, they realize that just because you don't follow a prescribed path, it doesn't mean that you're giving up or that you're losing hope. It's just that you're reframing it in a way that's more appropriate for where you are at that time. So when it comes down to sort of difficult decision making, if you're in a decision point and you don't have that much time to think about it, you don't have many other resources to contact, I think it's really helpful to always take a step back and reassess where you are as a doctor and where the patient is and what their heart's telling them.
So I think with a cancer diagnosis, one of the biggest things is this complete lack of control. You feel like, oh my gosh, there was this thing growing inside me and I didn't know it. Or now this has happened to me and all these things now subsequently have to happen to me. And it's just feeling very, very out of control. And then you don't know what's going to happen if you do all the treatments or if you do everything that's prescribed. And that's incredibly frightening. I mean, we all have control issues, but it's very frightening in that setting. So I really see myself more as an educator with options. So when I present to patients various treatment options, I really go through, this is standard of care, this is how we can modify it, or you can do nothing, and then this is the outcome with this is the known or the studies that show the various outcomes with all of this. So I really see my role as an educator. I try not to put my own value system on anyone or prescribe anything, if that makes sense. I really see it as I'm to tell you what the standard options are, what the modified options might be, and there's always the route of, we do nothing but support you, and then you can, pursue other options as you said you did. So I think that helps me. And then, like you said, you get to know a patient better. You get to understand, where they, where not just their value system, but just where they are in their lives, what their goals are, and then I think you can work together to move forward to come up with something that's comfortable for both of you.
how often does it happen with you guys? And this, I think, would go for everybody that, like, my brother was very sick, and he had one set of things on a directive, yet my mom was always jumping in and saying, no, keep them going. And like family dynamics on this, because people get pretty weak toward the end, and they might have one wish, but then the family wants every last day. So just in general, as doctors, how do you balance that?
So yes, I think when you have a diagnosis like cancer, it brings out all of the various dynamics in your family because you're facing a catastrophic event in your life, and so it becomes complex. So what's really important to me is for me to understand the wishes of my patient, and we always hope to do that before a patient is in a place where they couldn't make decisions for themselves. So our greatest hope is that we have those discussions early so that we can respect what our patient's wishes would be. And even though it can be difficult, as you said, if another family member's, we really, I really focus on this, he's told me that this is what he'd want, and so we're going to have to move forward with what they would want. But I'll tell you, it's really hard to have end-of-life discussions. It's really hard to have goals discussions. In fact, there's data that shows that looking at oncologists who actually treat patients with cancer who are within 3 to 6 months of potentially end of life, I think less than 50% have actually had a goals of care or an end-of-life discussion. So it's not an easy discussion to have. I mean, we're doctors. This is what we do. This is something that's not uncommon in our practice, but it's still really difficult for us to broach these issues with patients. But it's really important to avoid conflict at the end.
Yeah, I think I agree 100% with what you're saying, and I see this a lot in our patients when they're coming in for their initial consultation. And what I found is that a lot of this information comes really just from my own observations of what's going on with the patient and their interaction with whoever they happen to bring with them, if they come alone, what sort of documentation they send in, and even just talking to them briefly. And even though it may not necessarily be directly said, it does sort of fall out that there is one person that they lean on primarily to help them with a lot of the process. And so after really trying to set some expectations with the patient, I always want to see if whoever they're with has that sort of same expectation made clear to them as well. And so part of it comes with in the preoperative setting, we do a lot of counseling about risks, benefits, alternatives to surgery, similarly in the way that you do on the oncology side. And quite often we're talking about risks and benefits with the patient and whoever their designated person is at that time. And so I always make a point to see that everybody there is in agreement. And so when we have more complex family structures surrounding a patient, I always want to know, what's the patient's expectation by asking them directly and try to get a sense of who their next person to call is. Sometimes it's obvious. They're like, oh, this is my husband. He's taking me home from the hospital. But sometimes it's not. There may be a child or a sibling there who just happens to be free on that particular appointment day. And then I do try to make a point to ask whoever's there, oh, should I contact you about this, or is this someone else? And a lot of times the patients will identify another family member who they feel can advocate on their behalf, or another person who's very important to them. Now, the thing that often gets a little sticky is when we have people asking us as physicians, what would you do? If this was your dad, what would you do? If this is your partner, what would you do? And I'm not sure I've come up with a great answer for that quite yet. I think a lot of the times we just need to remind everybody involved that no family is the same as the other. No person's expectations or goals are the same as another person's, and try to relieve a little bit of the pressure of the decision making from them and just let them know that what they're feeling is entirely universal, and that if there's a question that they have, it's already been asked before, so they're not coming up with some burden on it or some sort of crazy idea, And so I think a lot of it is really normalizing the process and making sure that people feel that there are resources and that other people have been down the same path and that they're not alone.
On that, we're going to get back to Janice's other series that's downstairs. So these images they're really strong. They really like I look at them and I like this, the second one from the left there, sort of you're trapped in this space and there's sort of this silent scream on this one. So why don't you talk about when you did these, exactly where you were in your treatment, what was going on in your head when you did these, since someone else, this is also someone else took these, right? These were.
But it was my prompting. I chose the positioning. It was, they just were facilitating by shooting what I directed.
So I think these, because they're closer up, they're almost more powerful than the larger series, and the one all the way on the left there with the neck, it almost looks like your neck is getting ready to be cut. There's blood on it. So, I mean, this is a really dark series, and you were dealing with some really serious things. So I'm not even sure of my question here. It's just, they're so powerful. So why don't you talk about them? And then also, I want to know if you guys look at this work and you can relate this to other patients, sort of the process that they've had to go through.
It was totally random when I positioned myself, even the undressing. I almost didn't think about it. I just did it. And it was shortly after my surgery. I think it was maybe 2 weeks after my surgery. Like I said, the surgery was the easiest part because it, left me with no side effects. And I think it was just how I was feeling. I was scared because I knew I was not going to go the traditional route. There's not a lot of backup for when you want to do alternative medicine in this country, especially. So, I was very frightened, and I also didn't know, once you have cancer, you're always worried that it's going to come back. It was interesting, the comment that you made about how you don't cure lots of diseases. Cancer, it's just different. I can't really describe what that feeling is like, but everyone that I speak to that has it too, they always wonder, is their next MRI, is their next CT going to show that it's back? And then what do they do? I think it was a combination, since I had opted out of the traditional form of therapy for it, and just my own fear as I was trying to accept the fact that, I could possibly die.
So you had other people shooting you. Were you surprised how strong these images were?
Oh, yeah. Yeah, I didn't know. It wasn't until I saw the images that I realized how shocking I was. I didn't know.
And did you look at them and go, like the one with the hand over your mouth or the one where you're sort of confined into a space there, did you look at them afterward and go, yes, that's it, that's how I feel?
Yes, but the one where I'm confined into the space, well, they're all manipulated, but that box that my head is in, I did that afterwards. That's total manipulation. And when I looked at that photograph, I felt it needed that. I felt I needed to have that there.
And what do you guys think when you look at these, comparing them to other patients and interacting with your patients?
Right. And when I saw these, what first really struck me was this folding inwards and this collapse and almost like this memory of pain. And the reason why it really stood out to me is that often when I look at my patients post-operatively, the ones who are in pain are not the ones that you see on TV crying, thrashing, screaming, making a big fuss, but they're the ones who are very quiet, like folding in on themselves in bed, very silent. They may be crying, they may be not, but it's more of a stillness that I see that tells me that their pain is perhaps not, I wouldn't say genuine, because people feel pain the way they feel pain, but something that's very, like, to be taken seriously. And it's not necessarily an outward demonstration to others, but more of a trying to enclose upon themselves. So that's what really stood out to me.
So I'm actually just seeing these for the first time. And it feels like overwhelming grief to me. And so in just kind of so many ways. I don't know how else to, it just feels, I mean, I feel like you could be grieving about anything, and not knowing your background. If I just saw these, it just feels like being helpless and grieving, and that's what strikes me in this, the emotion that strikes me with these.
Powerlessness.
Yeah.
I felt powerless.
Yeah. And it's just, like I said, that
It was
lack of
overwhelming.
control. Yeah, just complete lack of control.
I mean, you weren't in any physical pain,
No,
right?
none.
Like, you didn't even know
None.
you had the tumor, so this is all sort of the emotional aspect of the
Yeah.
cancer.
Like I said, after the surgery, I mean, 2 days later, they wanted me to stay in the hospital for 5 days. I mean, as soon as they stopped the little pain drip, I was like, I'm out of here. I was fine. I was walking around. I like, even shortly after the surgery, I was cruising the hospital. I felt almost nothing.
All right. Well, I want to end with Janice and I have had a couple discussions about treatment and sort of advances in treatment, and that a lot of the things being done are sort of older, like you were saying, a lot of things hadn't changed in decades. So what is on the horizon? What has really changed? And especially for the students, what might they have in 10 years to treat someone like Janice that is coming online now?
Sure. So from a surgical standpoint, I think a lot of the new developments are increasingly minimal. And so when you think about the treatment of cancers back in the old day, it was very much maximally invasive. We joke about it, calling it single port surgery, because you make one big incision from stem to stern. But as we move forward, I think everything is getting smaller and smaller, meaning that the footprint of the surgeon inside the person's body is smaller and smaller. And at this point right now, our current standard of care for treating colon cancers or rectal cancers is to approach this laparoscopically. So using very small incisions, the help of a small camera to look around on the inside of the belly and to reduce the amount of physical trauma to the inside of the abdomen by very delicately picking apart the tissues. This is done either with the surgeon's two hands controlling the instruments, or in the more newfangled approaches, robotically speaking, where we have our surgeons sitting at a console and those instruments being directed from the console, kind of like a video game. But I think what's very exciting these days is the development of endoluminal surgery. And for those of you who are not familiar with that, it's actually removing concerning lesions from the inside of the colon just through the inside of the colon, kind of like you're doing it through a colonoscopy. And the idea here is that if you're trying to reduce the amount of physical trauma that the patient sustains during an operation, the idea is to do less, not more. And if you're able to remove less, not more, and yet still have that be oncologically sound, then why are we not trying that? And so it's in some ways like very complicated plumbing, but you know, when you think about your intestines, you are just one long pipe from your mouth all the way to your bottom. So perhaps that's not too bad of a metaphor to think about.
So there are a lot of advances in cancer care. So we also are looking at patients more individually now. So if we speak broadly about tumors, there's a focus on actually looking at the characteristics of individual tumors to identify particular mutations that can guide therapy. So instead of lumping patients together as we've done traditionally based on the stage or type of tumor patients have, we're now looking at splitting patients based on potentially specific genomic or genetic alterations a tumor may have that we can target. So, for example, in lung cancer now, therapy is very specialized based on what mutation may be present and may be driving the tumor. And in fact, some of these mutations are present in less than 5% of patients who present with disease. So we're becoming splitters, not lumpers, if you will, which I think is really fantastic because it's allowing for very tailored patient care. Kind of what you already said about the cancer oncotyping that you did, which gave you a risk assessment and then the benefit of potential chemotherapy. That's kind of that tailored approach. Also, what's, I think, exciting in cancer care now is that when we think of typical chemotherapy, we think of DNA damaging agents, but we've come a long way from that. We're now looking at targeted therapies, those potential driving mutations or pathways that may be causing the cancer to spread and progress. We have drugs now that are potentially targeting those, such as tyrosine kinase inhibitors, monoclonal antibodies. These drugs are actually much better tolerated. And now we're also in an era of immunotherapy, which is using monoclonal antibodies to kind of reactivate your own T cells to fight the cancer, which is really exciting. There's been a broad approval for immunotherapy, these checkpoint inhibitors, over the last few years across multiple tumor types, which is really advanced cancer care. There's more sophisticated immunotherapy, modulating agents that are being evaluated. So I think it's actually a really exciting time in oncology because we've got a broad treatment approach. We're tailoring therapy, and that's why, here at Norris, we're all quite specialized. I think none of us are just general oncologists because to really understand the diseases, we're all specialized within a particular tumor type because there's so much happening in the diseases moving forward. So I actually think it's a really interesting, really great time for oncology, and it's kind of what I just want to go back to what I said earlier. There is always a fear of death with cancer. There's always that looming, and I have patients say that they live from scan to scan because they're just never sure if they can't, is the next scan going to be the one that shows that the cancer's back and that's it. But I think, we have a sign outside of Norris that says we're going to make cancer a disease of the past, and I hope that's true. But I'm also hopeful that we'll turn cancer, a lot of different cancers, into HIV, where patients are living normal lifespans, taking 1 pill or 2 pills a day, and just managing their disease, but able to live with the cancer. So that's what I was referring to in terms of chronicity of disease. And we have moved in that direction in many diseases, such as CML, various leukemias. So we're making a lot of progress. Think about oncology.
Are there any questions for anybody up here on the stage?
There's a lot of information right now about burnout. And as a social worker, I get that information, and I just read that social workers crash at 3 years. So I don't know, doctors aren't mandated like we are to get therapy and do things like if you're having a hard time, because we're perceived as damaging our patients if we don't manage our own stuff. So I'm really curious, as we deal with this in our department and look at it, as you work longer in a setting, you want to have an understanding of the sustainability. So I'm just curious, as physicians, how you live with these topics, these issues in people's lives, and see these people as humans who may or may not make it through, and how you manage that in a profession where you're really seen as the ones who are going to make it all right.
I think as surgeons, we have a really, really long way to go as far as figuring out the best way to manage burnout in ourselves and in our trainees. I know a lot of it, personally, I thought about quitting almost every single day of my second year of residency. And it really took a lot not to. And part of that was just simply the momentum that training brings with it. Every day is going to end and the new day is going to begin. And so part of the development of coping mechanisms was, it was very painful at the time, but now that they're in place, I think it's even harder to change them if they're maladaptive. So in dealing with a lot of the very difficult stories that we encounter every day and the very dramatic and traumatic stories that we encounter every day, it's absolutely necessary to have an escape hatch or some sort of way to get out of that compartment. Because if I'm operating and I have a belly open on the table and I'm thinking to myself, oh, Christine, don't mess this up because this woman has 3 kids and, her husband has cancer and she needs to get back to taking care of them. I would never be able to finish the case. It would be absolutely paralyzing. And so and I'm particularly concerned about helping the trainees that we have to develop appropriate or even any coping mechanisms at this point, because the tendency to sort of shove all of these emotions into a box and just kind of deal with them later is so great. And there's really not so much external motivation to deal with these things right now, just simply the way hospital cultures are and how training cultures are. And so it's sort of events like these that I think help people to understand that there are outlets for their angst and there's places to put it, and other people who have had similar experiences and maybe are able to share the ways they cope with things that, are incredibly difficult to process events in one person, let alone the 20 people who are rolling through your clinic that day.
I don't think we deal with it well as physicians at all, particularly as an oncologist. I used to be the program director for our fellowship program, and I brought this up as a significant issue because I was having a hard time dealing with it. When I first started, I was dreaming about my patients. It was really, really difficult. And over the years, I've established my own coping mechanisms, and my own belief system helps me deal with my day-to-day life, but it's not easy. We spend a lot of clinic days crying with our patients, and it affects me. It really affects me. And there was nowhere, my colleagues, when I first started, would go to them and say, like, how? And no one had anything to offer, just very honestly. I'm hoping that's changing in medical education. I'm hoping we're dealing with it. Interestingly, when I brought in this social worker to help with our fellows, people thought it was, the trainees didn't really appreciate it. The fellows felt like it was a waste of time. It wasn't a lecture series that they wanted to be a part of. And I still have a hard time with it. There are really bad days, and then there are good days. But I think just my belief system that I've created and has helped me get through it, but I don't think there's any formal process. When I first started, my father would say, "Don't tell me about these cases," because I wasn't married at the time and I was young, and I would tell my dad on my drive home, and my dad would be like, "Don't tell me, Syma, it affects me too much." And I was living those, and then I married a person who's not a doctor, and then he would say, "Syma, don't tell me about this. I can't handle it." And I thought, I'm handling this. Who's going to help me? And so then I think it's individualized, and I do things. I work out. I do this or that. But it's something that I've had to create for myself. And I hope medical education is better, and I hope that we can do more to support not only our trainees but us. So anyway, that's it. I could go on and on.
Thank you so much. I just feel so privileged to hear this conversation, and thank you all for being here. I feel like the way, and that question was wonderful, the way we have been able to hear from Janice, whose work shows us much of her experience, and we talk about events like this helping our future physicians and future health professionals understand their patients. I think this also helps all of us understand who we are as healthcare professionals and who we're becoming and how we become who we are. So it works both ways, and I am really grateful to you, Ted, for facilitating this, Janice, for sharing your story and your work with us, and to Dr. Hsieh and Dr. Iqbal. So thank you so much.